Hello, this is the NICU Lived Network, and we are your hosts. I'm Melinda.
I'm Nat.
And I'm Emma. We are all NICU mothers using our lived experience to partner with health professionals to impact research, advocacy, and clinical practice.
We hope you enjoy this episode.
Hi everyone, it's Nat and Mel here. Thanks for joining us on another episode of the NICU Live Network. We're very excited about today because we welcome back Adjunct Associate Professor Miranda Davies. Welcome back, Miranda.
Thanks for having me back, Nat and Mel.
It's so nice to have you back, and we love your background, like totally jealous. It's amazing.
I love the fact that it's real.
I know, yeah, absolutely.
Perfect.
Just a quick little intro about Miranda. So she is a perinatal epidemiologist, and she is also the president of the Perinatal Society of Australia and New Zealand, also known as PSANS. So it's wonderful to I think it's been 2 years since we last spoke to you. And so for our viewers, because it's been a while, do you mind kind of recapping who you are and where you work and what you do?
Yep, no worries. So as you said, I'm a perinatal epidemiologist. So I am a scientist researcher that tries to understand or improve pregnancy outcomes, particularly interested in preventing stillbirth, preterm birth, fetal growth restriction, and trying to develop ways that we can better understand those processes and prevent them from happening to families. So I'm based in Melbourne. I'm at the Hudson Institute in a centre called the Ritchie Centre, and I'm very lucky because the research institute's at a big hospital, so we can do scientific discoveries alongside clinical research.
Amazing. And we're curious, Miranda, we were just talking before about some of your work, and do you have any kind of really exciting or big projects that you're working on that you'd like to tell us about?
Yeah, so what I wanted to speak to you today is about a program of work that we've been developing over the last couple of years that seeks to understand why adverse preterm outcomes occur. So most of the stillbirths occur in the preterm period. We're not very good at preventing preterm stillbirth. We don't always understand why women go into preterm labour, why they develop things such as fetal growth restriction. And we've been really interested in trying to understand what we don't know in that space. And most of the research to date really focuses on the placenta. And this is because the placenta is obviously super important to the outcomes of pregnancy. But what hasn't happened is a good study of the endometrium, so where the embryo first implants and where the placenta develops. Basically the mother's uterus, her contribution to those adverse outcomes, and potentially that's the gap in our knowledge that has meant that we haven't been able to progress the field forward as quickly as we would have hoped.
When we first kind of got in touch, I was like, what is the endometrium? I've never heard of it. The only reference that it reminded me of was like endometriosis. So I'm assuming they kind of connected those two things.
Yes, so your endometrium is essentially what is regrown every month after you have a menstrual cycle. And it's the environment that is there to support a fertilized egg if pregnancy occurs. And so endometriosis is a condition where there's abnormalities in that endometrium, and that is a diagnosed condition which has a lot of symptoms and is known to be associated with having a higher rate of adverse pregnancy outcomes. The problem is that we know that particularly for endometriosis, it can take women 7 to 10 years to be diagnosed. And there's a lot of symptoms that go along with endometriosis, like heavy menstrual bleeding, pain, and women are entering pregnancy with those characteristics, but they don't know that they have endometriosis, or maybe they don't quite have endometriosis, but it's sort of a spectrum of abnormalities in that endometrium.
Yeah.
And so it means that the structure or the different information that the endometrium would, I guess, signal to the egg to support implantation, the placenta forming, is different. And so it could mean that the placenta is forming in a way that's not optimal, which then results in different adverse pregnancy outcomes.
Yeah.
So the research that we're doing is trying to understand what those variations in the endometrium might be, women who've had adverse outcomes. And it's a study we can chat about in a minute where we're collecting menstrual fluid or your period from women who've experienced adverse outcomes, and we're able to measure all the different things that exist, because the tissue that is in your period is the endometrium at the time that the egg would have implanted. So we know its structure, we know what's in it, and so it can tell us what that environment would have been at that time, to help us understand if there are differences in that for women who've had different outcomes, and also healthy term outcomes of babies that have grown normally. The other component of that, though, is obviously it's not always that easy to collect samples and tissue, and that's invasive in a sense, because it's in the absence of pregnancy. But can we also capture characteristics? So can women tell us about their periods? So things like how heavy they are. Do they have lots of blood clots? Are they very light? Do they have spotting at different times in the month? Is there a lot of pain? A lot of pain can usually mean a lot of inflammation. And what does that mean in terms of what their endometrium might look like? So we've got a few studies running where we're collecting biological samples, and we're doing clinical surveys. We're looking backwards in some studies, we're looking forwards in some studies, to try and work out if we can actually identify new causes and therefore potentially new targets for preconception preventative care. We can help women who don't understand why. So we don't always uncover a reason for a loss or why a preterm birth has occurred. By understanding menstruation and her endometrium, we might be able to say, actually, the structure of your endometrium is slightly different, and this is why the placenta didn't form the way it could. And then other really clever people can think about drugs, therapies, approaches to target that to then optimize pregnancies moving forward.
Oh, wow. That
No, I'm just so fascinated. So my personal history is I was diagnosed with endometriosis at 18, and my first pregnancy was at 24. But even before I fell pregnant, I remember, so what, Elijah's 22 now, so this was a while ago. But the doctor said because of my conditions that he said 3 things will happen. Either you won't fall pregnant, you won't keep the baby, or you'll have them early. And out of those 3 options, having them early at least gave me a chance of being a mum. And I started contractions at 29 weeks, but held them off to 34 with him. But yeah, like, it's just so scary. And all the things that you mentioned, and even though I'm on the other side now, my youngest is 18, I'm still having all of those symptoms of, the heavy periods and the clots and all of that. And it's just been a lifelong thing that women are going through. So I think the studies that you're doing is so important. It'd be definitely one I would have put my hand up for.
Yeah, I think there's huge potential in the future for women with endometriosis. Where I work, there's a lot of incredible scientists who are discovering approaches to treating endometriosis. They're involved in this team as well, because obviously their understanding of the pathways that lead to endometriosis have huge potentials for women, even if they don't have endometriosis, but maybe they have heavy menstrual bleeding that's not endometriosis. We're learning a lot more about another condition called adenomyosis, which is another abnormal endometrial condition. And I think as we learn more and more, and we address the gender bias in research that has meant a lot of these studies.
I was just about to say, why don't we know more about this?
Yeah. I mean, periods are a bit icky, right? So it's a stigmatized fluid. And to me, it's hilarious that we would collect poo samples and that's fine. And we use that to screen people, or diagnose things all the time. But that we haven't been considering menstrual fluid as another source of information to help diagnose conditions and understand them. It boggles my mind. But I think where women are talking more, we're more involved in research now. We're very passionate about addressing this gender bias. And so periods are not icky anymore. They're exciting. And they might be why this field hasn't progressed as it should. And I'm excited to be part of the scientists that are pushing forward in that space.
Oh, that's amazing. Thanks, Mel, because I was thinking the same thing as like when you said, Miranda, we haven't really done too much in this area. I was like, why not? Because millions of babies are born each year. Billions.
I think one of the other challenges too, Nat, is until recently, the only way to study the endometrium was to actually take a biopsy. So have a surgery, go in.
Oh, okay.
Yeah, and it's only been
like a laparoscopy or something.
So laparoscopy would be going in through the stomach. So that's what you would have had for your endometriosis. But to sample the endometrium, that's inside the uterus. So they'd have to go in through your vagina, in through your cervix, to then. Yeah. So sort of like if you were to have
a higher up pap smear kind of thing.
Yeah, definitely like a really high up pap smear. So if anyone's ever had, I say that the placenta didn't come out and they had to do a procedure where they go in to get it out. It's
that
all
was
the
my
way.
third son.
So it's all the way inside, right? So it's quite invasive.
Yeah.
But one of the teams that I worked with has been quite pioneering in characterizing menstrual fluid. And obviously for women who menstruate every month, that it's shed, and so we can collect it in that sense. And now there's the potential for non-invasive ways to measure the endometrium. Previous studies too were usually in women who had other things happening, so there was a pathology or there was a problem, so they were having a surgery, so you're collected at the same time. Whereas now we have the potential to collect it from everybody, and there's quite a lot of work going on in the menstrual health space broadly, very much applied to conditions like endometriosis, not so much to pregnancy, because I guess you sort of think periods and pregnancy don't really go together because they're in opposition.
It stops once you're pregnant. Yeah.
And so when you mentioned that you've developed, or there are now, they've emerging different ways to kind of collect menstrual blood, and is that through mainly cups or anything else?
Yeah, so I think at the moment the main way that we collect menstrual fluid for research is through cups. There are teams around the world actually developing different things like special pads or smaller devices. Particularly for women with endometriosis, the cups can be quite uncomfortable, and so developing more comfortable products is happening. At the moment, we're at the mercy of what's been developed, which is challenging, but lots of women do use menstrual cups as a sort of an environmental approach to dealing with their menstrual cycles. And it does allow women to self-collect it. And so in the study that we're doing, women are sent a kit at home. So they're sent a cup, they're sent tubes. They get instructions on when to insert the cup and for how long. They remove their cup and they put it into another tube, and it all is packaged up, and it's sort of, you're not going anywhere. You're doing it all on your own, at least. You don't need a researcher involved.
Oh, okay. And then what happens once it's all packaged up? Do they just drop it to a centre, or they put it in them?
So for our study, we have a medical courier. So women who participate let us know, because obviously cycles are variable. You might know your cycle's 28 days or 30 days, but it might come a day or two early. So women who participate in our research keep in touch with our researchers who are managing the recruitment component of this study. And they are advised to put the cup in on the second day of their cycle and wear it for a period of time. And you could just notify there's a courier service that's notified, and you just pop it wherever you are. You could be at work, you'll be at home, it doesn't matter where you are. It's a medical courier, no one will know what's even being collected, and they just come to you, collect it in. It's all sealed up. It's all very good. We've got to keep it cold and out of the light, and all of the things to make sure that the components in the menstrual fluid remain measurable. Yeah, and a courier just comes and picks it up at your convenient location.
Yeah, that's great. And is it just for Victoria, or is it for other Like,
So at the moment, it's just for Victoria, but we
Yeah.
do have the potential with collaborators in other states to extend to other states, because essentially it's a simple processing procedure at our end, and then later it can be shipped down to Victoria for the more complicated analysis. Some of the studies have to be done on fresh menstrual fluids, so they can only be done by our Victorian team. But there is potential for other states. And I just wanted to also say the courier doesn't know what they're collecting. So as far as they're concerned, it's just some sort of biological. And it's no different to services where they might come and pick up poo in cups and things like that. So that's their job, but they don't know. It could be a blood, it could be poo, it could be spit, it could be anything. They don't know what they're collecting.
Yeah. I'm going to put the banner up on the screen so that people can see it. So we're talking about the Endometrial Origins of Stillbirth, the EOS study, which is great. So I was just reading. So it's aimed at better understanding the endometrium or the lining of the uterus in women who have experienced a pregnancy loss, either as a late miscarriage or preterm stillbirth or other adverse pregnancy outcomes. And then, so you're going to compare the endometrium of women who have had a full-term live birth. Like, it's just so fascinating, isn't it? And then to, I guess, compare the two so that you have treatment options. Like, I'm fascinated. Where do you see that going? I've got two questions. Where do you see that going in terms of treatment? And the other thing is too, is there anything that women, or whether the study would help with that? Like, is there anything that we can do, whether it's, to be better prepared? Like, how do we prepare the lining to be better for optimal pregnancy? Is it nutrition? Is it, being in a healthy weight? Is it are there things that we can help support what our body needs to be able to do that?
So I guess at this point, we don't know what the differences are that link to it. And I think women, when they've experienced an adverse pregnancy outcome, they tend to look to what I could have done, what I shouldn't have done. And it may be that there's absolutely nothing that you should or could have done. This is the way the hormones in your body are working. What we want to understand is what those differences are. And maybe there are lifestyle things that could help support or optimize outcomes, just like we would say for healthy pregnancies in general. In general, I think the benefit here is we can identify, say, from preconception care. Let's say we understand that it's something to do with the immune system. So I'm quite interested. There's studies now that clearly show that women who receive vaccinations in pregnancy are less likely to experience a preterm birth or a stillbirth unrelated to infection. So there's something about the way a vaccination changes the immune system that is protective for pregnancy. This is probably acting in the endometrium, and it's looking at cells or the immune cell profile in your endometrium. And maybe it's changing things that are helping that pregnancy be more healthy, more successful, right? So by understanding what differences in structure, function, immune system, in the different outcomes, we can then understand how we could maybe target different things. So let's say we know, I've got this idea, right, that maybe it's the structure's normal, but they're not secreting the right messages to help the placenta form for fetal growth restriction. Or maybe the structure's not quite right in how it's arranged, plus it's not secreting things. Maybe now we've got a stillbirth. Or if the structure, so maybe the structure is not okay, but it's secreting things fine. Now we've got a spontaneous preterm birth, and we can understand which way these things work together. And it might be, if it's immune based, maybe that's the group that the aspirin works quite well in. We know it works in terms of hypertension and preeclampsia, which is also a placental problem, but there's secondary evidence there around now potentially for recurrent pregnancy loss and stillbirth. And maybe it's via that mechanism for that group, whereas maybe there's immune cell differences that activate for preterm birth onset. Or so sorry, complicated answer. I don't think I would be. I don't want to say women need to do something or it's their fault that made their endometrium not ideal. We don't know yet, but there's the potential for preconception understanding or maybe even development of pregnancy therapies. So we know that your endometrium was like this, and so we can support that in pregnancy, which might be like the aspirin story or other things in that space. Maybe it's monitoring. This is a pregnancy that's at risk of late, like the baby's not going to grow well at the end because of what we know. Let's do some extra monitoring at the end so that we can do timing of birth well, so that we don't miss that baby that doesn't grow and then sadly dies.
It's really like a big discovery thing,
there's
isn't
huge
it?
potential, and there's so much incredible work happening around therapies for the placenta. So many researchers are trying to come up with treatments for the placenta. This work might help us understand which of those cool, exciting new therapies coming out are for which types of endometrial or which type of woman.
So it's more like precision kind of healthcare.
This idea of understanding, and we call it phenotyping or characterizing a condition more specifically, so that we can target the right therapy or the right approach based on that specific mechanism. I mean, and ideally we would hope we could detect these things in a blood test. So it's completely non-invasive if you're pregnant. Not all women have preconception care to know. Or one of the other studies that we're doing at the moment is around this very comprehensive menstrual health survey, which women who participate in the menstrual fluid study also do. Where we're so this study is called Your Period and Your Pregnancy. And these are women who we are recruiting in early pregnancy. There's going to be over 1,000 women in the study. We've got a bit over 300 recruited already. This is just at the hospital that I work at in Victoria, Monash. But women complete a survey that we've developed that captures everything and anything you can think about in terms of your menstrual health. We've used tools that they use in research for teenagers for endometriosis diagnosis. We've worked with the gynecologists around how they capture information clinically to develop a tool. And then these women have their pregnancies, and we are collecting pregnancy information, investigations, results and tests. And a subgroup of women have consented for us to collect tissue at the time of their birth. So that will be their placenta. And if they have a cesarean section, we'd also be asking to collect some extra samples from them at the time of the cesarean section. And then we can hopefully correlate the survey information. So which parameters are helpful or not helpful? Do they relate to things that we can measure at the birth? Do they relate to clinical things that can help clinicians know what tests or where or what they should be looking at? And then bringing that together with this menstrual fluid study to say, do those questions also reflect very clear structural, secreted, immune differences in women who've had an adverse outcome in the past? And we bring it all together, hopefully, to understand what. Yeah,
that's amazing and pretty kind of comprehensive. And I'm interested in the survey. So the survey, what does that look like? Is it just like a thing of multi-choice questions, or is there like free text as well where women kind of describe if they've had certain symptoms? And is it something that they fill out themselves, or is it something that somebody kind of do they do it with somebody?
So we've got some fabulous research midwives that are doing the recruitment in clinic. The women complete the survey themselves, but we have our team around to support if they need some help or clarification, particularly things like cycle length, period length. There's actually a huge space, I think, for women to have menstrual education about what these things are. A lot of women have very heavy periods and think that it's totally normal even. So what we accept or don't accept. Series of questions. We also have lots of pictures, because if I was to say, do you have a heavy period? Heavy to you might be different to Nat. But if we show you a picture of a pad, they're drawings, cartoons. They're not actual pictures. If we show you a picture of a pad and how full it is, and a tampon and how full it is, and over how many hours would it look like that, we can start more objectively and consistently measure things like that. We have pain on scales. Pain is very personal anyway. And so I think, when we think about things like abnormal menstrual bleeding, you've got the definition is it interferes with your life. So it might not be that heavy, but it's very painful. And I think we know from the endometriosis story, we have women with very small amounts of disease who are very debilitated by it, and equally women who have disease all through their pelvic cavity that would say, oh, it's actually not that bad for me. So it's quite subjective in that sense. But we try and use validated or tools that allow us to sort of at least try and consistently measure it across cycles. We're recruiting women in early pregnancy too, so that their memory of their cycles prior to becoming pregnant is more fresh. Because if you ask people in the past, it can be harder to recall. And also our cycles change over our lives. And actually after pregnancy too, potentially some of our work showing that women's cycles do change after pregnancy, which would make sense. It's a big change to the endometrium for it to then, and hormonal changes for it to then go back to what it was or to change in a different way. So yeah, lots of pictures, lots of questions, potential for open-ended. It's comprehensive, very comprehensive.
Is this kind of work happening anywhere else in the world?
Good question.
That you know of?
So there's quite a bit of work happening in the gynecological conditions space. So a lot of interest with endometriosis. Obviously, that's an area that needs a lot of work. In terms of the pregnancy space, no, there's not much happening at all. There's been a handful of studies that have, say, looked at tissue that's been collected, and that's invasive collections, around recurrent pregnancy loss, preterm birth, and obviously a lot in preeclampsia, in that preeclampsia space. In terms of menstruation as a characteristic, there's, I think, a handful of studies that have looked at it. So there's a lot that we can answer still. And certainly the menstruation research in terms of describing it, it's usually quite hard exposure information, like your period started early. Or, like, so sort of like, is it irregular? How early did it start? Rather than, clots and pain and volumes and things like that, because they've been a little bit trickier to capture. So we're quite interested too, looking at the menstrual fluid, comparing how women describe their cycle versus what we get. So if they say they have large clots, do we notice clots? Or do we notice things that relate to clotting that we can measure in their fluid that go, yep, that, that's like, we can correlate those symptoms.
Well, that's great, because I just feel like a lot of them, if you ask them, that, particularly if it's a really kind of severe, like, I think they'd be like, they'd open text or just an opportunity to tell someone their experience. I think, you could potentially, like, the stories that could potentially come out of it, I think would be quite insightful.
I think even just asking women makes them realize, oh, that's not normal, actually. And I think, for our prospective cohort, we don't want women who know they already have endometriosis, for example, in the study, because they would have a higher rate of potentially adverse outcomes, preterm birth, etc. But there will be a subset of women who report heavy menstrual bleeding or symptoms indicative of heavy menstrual bleeding that may actually have endometriosis that they don't know yet. And it might flag for them to go and speak to their healthcare provider about their periods later. So we're hoping there's the potential even there to help identify women who might have a condition they didn't know that they had.
And that in itself is a wonderful service. And I was just wondering, hearing about it, it just sounds very exciting in terms of, it really does sound like a discovery approach where, there are all these unknown questions and, you're even, exploring ways that it can help families on the ground at the end of the day. But how are you going to kind of inform or kind of communicate to families how you're going? For those families that have participated in the research, like how do you talk to them or update them about the project?
Yeah. So I think the plan in terms of informing the people who've participated, we'll do that through newsletters and information and updates about the study findings as we collect them.
Yeah.
You're both very familiar with research in the sense that we can't give individual results, and actually they don't mean anything yet because we haven't actually validated them as clinical tools. But we can certainly say that from our study we found these were the things, or these were the characteristics that related to that outcome. I think I'd be really excited if anyone who participates also wants to be involved in terms of their lived experience of the research and things that can help us inform the research. We do have a couple of people with lived experience that sit on our steering committee, and their contributions and ideas have been invaluable, and certainly things outside the box. So they might not necessarily relate to the questions we're answering now, but the application and how they would have, how that information would be helpful in the future, particularly around things like placenta autopsies and placenta pathology investigations and some of those components. So communication is key. And I think the other aspect here is that we're working with clinicians. So our team includes obstetricians, midwives, and gynecologists, so that we can sort of span that and make sure that anything that we do really has that, how will it be used clinically later to actually guide care? Does it relate to the tests and investigations that doctors do every day in their normal care? And bridging the gap, I think, too, between gynecology and obstetrics. So women might have trouble getting pregnant and they go and see a gynecologist for investigations and they learn things, but it doesn't always translate across then into the pregnancy care space. So thinking about pregnancy as a continuum, and also all of these conditions or outcomes as a continuum. So the study is called Endometrial Origins of Stillbirth, which is where we began. But most of the causes of stillbirth relate to the placenta and are things like preterm birth, fetal growth restriction, or they're unexplained, which might be something to do with an endometrial contribution. And maybe that's where we'll get to in the future. It's an endometrial derived adverse pregnancy outcome, and will help then with understanding why these adverse events occurred, which is also so important for families so that they can understand, but also really important for clinicians and researchers so that we can work out how to prevent those ones too.
Yeah, absolutely.
Sorry, I'm talking a lot. I love this project.
Yeah, it's fascinating, and it's so important too. Like when you do have results or you have outcomes, like how does that get translated back? And you're right, like, women will see different specialists for different reasons, but how are they all talking to each other so that it's a whole complete picture, because everything's connected.
I think that's the big thing as we move towards addressing gender bias in health. All of our research has always been done in males or male animals, where the cycle aspect has been wiped out. But we know hormones affect our immune system, our menstrual cycles, our cardiovascular. It affects everything. So bringing all of the multidisciplinary people together to look at sort of a whole system, I think will really help move the field forward.
It's wonderful.
I'm fascinated.
Is there a strong translation aspect of this study as well? Like once you've done that kind of discovery, is that the next part of it? Or? Yeah, okay. All right.
Yeah, so I think from a translation point of view, there's a couple of things. Once we've been able to identify what might be in the menstrual fluid that helps us, then we can start thinking about things like biomarkers or screening techniques, etc. I think we need to think a little bit about better ways to collect and measure menstrual fluid as well simultaneously. But you've got that aspect. And then if there are components of a woman's menstrual cycle that are really important for a clinician in early pregnancy to flag, we can think about how we might embed that in pre-pregnancy screening or early pregnancy screening. Very aware that our poor midwives and obstetricians have so many things that they have to capture now that it is not about adding more burden to their workload. But I do know for those obstetricians, particularly that I work with, that care for some of these women and families that experience terrible outcomes, they are very passionate about finding ways to prevent that occurring and preventing families having to experience that. So we'll work with the clinicians to see how best that translation aspect works. And then I guess it's something that I hope all of the really incredible minds across the world who are in this space in terms of therapeutics, treatments, developing things, can use the information that we develop to inform all of their programs. I think there's a lot of potential. It is blue sky, but I think there's huge potential.
Yeah, like you said, it's so not looked at and not studied, and every woman goes through it. Like it's just, and for such a big chunk of your life too, your period. And
it's such a critical aspect of your pregnancy. You've got your placenta joining to your endometrium. We study this a lot because obviously we can, but this is the other player. And in fact, it probably guides how the placenta develops. So it's even more important than the placenta.
Yeah.
I shouldn't say that because I do love the placenta, but equally important.
Yeah. Well, I mean, that's the fascination, that knowing that, and there's just hasn't been a focus on it before to this level. So it's going to resonate with so many people. Like it's just, we just don't talk about periods enough.
But it's
and you're right. Who would even think that there was a correlation?
Yeah, you sort of think, oh, your periods mean you didn't get pregnant, so it's not helpful. But like what happens is you get your period, and then over the next 2 weeks, it regrows, like everything that you've had in your period. And then at the point where you ovulate, so the chemicals that say release the egg, it tells the endometrium an egg's coming, and it does this thing. It's called desigillization, but essentially it means it just changes itself. So it's going from grow to like, oh, we need to be egg ready. So it rearranges its structure and it starts secreting. I call them come hither, like call the egg, like come hither, right? So they secrete these things because basically the egg the fertilized egg and the endometrium talk to each other. So it's called crosstalk. And it's saying like, I'm receptive, and the egg's like, I'm fertilized and I'm healthy or whatever. And then they talk to each other, and then that guides how it embeds and how the placenta forms, essentially. And there's like information like it needs to have no oxygen to make the blood vessels grow, because obviously the blood vessels in the mother have to connect to the placenta. So there's all of this crazy stuff that's chatting to each other all the time. And you can imagine, like, if your immune system's different and it's really inflamed, or maybe it's super thick and it can't get all the way through, or maybe it's not organized properly in the structure, the placenta can't do. So, and then if you're not pregnant, whatever it turned into to say, I'm ready for your egg, that's it then until you shed it, and it just sheds away. So you know at that point what it was at the come hither moment. Essentially. And so you know if it's like what's the come hither things it's secreting or whatever. And there's a really cool study they did with preeclampsia endometrium. So preterm births where it was invasive, they took a bit of endometrium from those preterm births. And they tried to grow placental cells and endometrial cells together. So you can put them in a dish and it's like a gel, and you can like pretend that pregnancy is happening and see how they grow together. And so basically the preeclampsia endometrium, the placenta cells couldn't grow as well into it, so they didn't go as far through. And they had like difference in those come hither molecules. And then in another dish they added the come hithers and it grew better. So like once we understand what's here, we can maybe add things in to help support that placentation process. So I guess, women who maybe have had a previous preterm birth or previous recurrent losses, we can modulate their come hithers, or we can help in that growing shifting. Like, what signal did it need to make it organized properly? Like there's so many different points potentially.
And like you were saying before, like that's exciting for like just on the ground to be like, oh, well, there's this, like if you could be so kind of explicit and say, there's an issue here at this point, and so we're going to give you this to help. And then it's like, do you know what I mean? It's like just to have that certainty with specific things, I think would be quite comforting. Or not certainty, but just like it's this fully customized kind of treatment for the woman. Like
and I think what we're going to learn is actually in the endometriosis space. So that thing I said, decidulization, that's what's different for endometriosis. That's how we know it's a different sort of and actually there's differences in stem cells, which I think is part of where they think endometriosis, you've got your retrograde menstruation. So instead of coming out, it goes down your fallopian tubes and into your pelvis, right? And then because they've got more stem cells, they stick places, and then they just respond to the hormones like anything does, and they grow and move around, right? We have increasing rates of women being diagnosed with endometriosis, increasing numbers of women with endometriosis in pregnancy, and a lot of women with endometriosis will have IVF to support their pregnancy, right?
I just about to ask the implications of that. Yes.
Yeah. So
how do you get the endometrium ready when IVF is, introducing an embryo?
IVF is a fabulous space where I think we can learn about this, because they know based on, you've got IVF where you've got stimulating the eggs. But you also have IVF where you're preparing for implantation. Understanding what hormone signals lead to the best structure.
They do that now?
Well, they do things now to prepare, but not thinking on this level of like, these are the ways the woman's endometrium have reorganized and what they're secreting. It's sort of more blanket, like these are the hormones that make it grow, and these are the hormones that trigger it to change. But as it triggers to change, maybe it needs some extra bits in there to say change better, or fix something that's not changing as well as it should. And I think in the IVF, in the endometriosis space, we're probably going to learn a lot, because there's a lot of work going on there, and we'll be able to translate a lot of that knowledge to then think about pregnancy in general, based on what pathways are identified. I think there's like huge. I mean, it's going to take probably 10 years or so, 20 years. I don't know, but it's cool.
Yeah, absolutely.
I can't believe it hasn't been done before.
We didn't care about it, Nat. We don't care that women have debilitating periods. Even things like premenstrual syndrome and PMDD, which is the severe form of PMS, women are just told, they're like, oh yeah, it's just part of it, suck it up. And now others are saying, no, that's actually a problem and could be treated and could improve your life. You don't have to just tolerate like having iron infusions because your period's so heavy. Like that's not normal.
Yeah.
And how amazing that you were able to kind of start piecing things together just through those conversations with people, and then kind of going and having a look at what's out there, and just like that's, and that's why I'm involved in this space, is because it was just like there are so many questions, and what do you do with the questions, kind of thing. Like, I
like to think, I'm got an inquisitive mind. I like to think that I hate not knowing something. Like it bothers me immensely when someone asks something and I don't know the answer to it, and I can't find the answer to it, and then it's almost a compulsion. It bothers me to work out whether there's something worth doing. So the nice answer is I'm interested in answering questions that are important, but actually it's I need to know things.
I love Well, we benefit from that, right? Like women everywhere are going to benefit from that. Curiosity.
Even if we find out lots of things don't matter, we can actually put that to rest. So
that's right. Yeah.
Yeah,
it's just as important to find out what works as well as what doesn't work. Yeah,
completely, like absolutely,
Yeah.
completely. And sometimes what you think you're going to find is not what you find, but you find something else through that journey that you hadn't quite connected. So it's still helpful.
And I think I love, like, what I like about, the kind of chats that we have is that, if more families watch them, then it'll kind of prompt them to kind of think about other questions or other things. And then that kind of just to start that conversation and to kind of start that whole wheel again as well. Like, I
think the other thing that's really important is breaking down this idea that sort of scientists and clinicians are up here and it's intimidating and scary. Like, yes, the place that someone has lived experience comes at is slightly different. But it's still very important and very valid. And sometimes it's actually, we already looked at all this and it's not something that needs to be looked at. But otherwise it might be just, we don't know. And actually, the more you hear the stories, the more us as scientists go, hang on.
Yeah.
I'm hearing this a bit, and clinicians do this all the time. Oh, I'm seeing this happen a bit with my patients.
Yeah.
I wonder if there's something in this I should look into. So I would say share things all the time. It builds the groundswell to go, actually.
Absolutely. This kind of little base of like things. And I just remember, like, there was, when I was doing that peer-to-peer support with families, they'd always ask these questions. I was like, what if anyone's done anything about this? Well, that's really interesting. Or just this, I kind of wish I kind of documented them. But it was always like just 100 things in my head, just, every time, someone asks you a question.
Right. Brilliant.
Thank you. Good on you, Miranda.
Yeah. I was just going to say, I was having a look at this particular study, the people that are eligible to be able to participate, but also where do people go to be able to find out more? I know that on the notes, and we'll have it all in the show notes as well, that if they live in Victoria, they're aged 18 to 40, have a menstrual period, have been pregnant in the last 3 years and are not on any contraceptives, that they'd be eligible to be part of it. Is that correct?
Yep. Yeah. And we have delineations of different outcomes that you might have experienced, trying to capture most of them. And also understanding that some of them overlap. So if your baby's been born preterm, you might also have had preeclampsia, or you might have also had fetal growth restriction. So some of those things go together. Information about participating is either via, there's a website on my work Hudson Institute webpage, and as you said, you'll pop that up. Also, this study initially was funded through the Stillbirth Foundation of Australia. We now have funding from the NHMRC to run the full program, but Stillbirth Foundation of Australia also do still have a website dedicated to that as well. But even just send me an email if you are unable to locate those two websites. We just have a sort of expression of interest, I guess, and then one of our research team will get in contact and have a chat about participation.
How long is the study? Like, how long is the recruitment process?
Until we get everybody, essentially. We've still got a little way to go, and we want to make sure that we recruit enough people that have experienced all of the different outcomes, so that we are able to meaningfully look at the data that we collect. I would love to have recruitment finished by the end of this year, that we can also, for those participants who've already been in the study, we can get information to them about how they've contributed to the scientific discoveries. In our consent process, women consent, I think, for up to 5 samples, understanding that you might want to participate, but it doesn't work 1 month because you're away, or you miss something, or, life, we know what it's like. And also that we might want to look at a few different things in your cycle. So you don't have to donate 5. We definitely would love 1. And we're quite flexible. You get to keep the cup if you like obviously you get to keep the cup, but
you wouldn't want them back.
Yeah, we've had people want to participate too because they've also been interested in trying a cup. They're quite expensive, so it's a good way to that you can have a try of a product in that sense as well.
Well, maybe too much information, but I personally use a cup. So, but I understand that if there was, it can be quite uncomfortable. You can feel like the pressure of it and things like that. So even the fact that you're looking at other options, I think it's just going to improve health and options for women.
So I'll definitely say not too much information. I love talking about periods. I accidentally do dinner parties sometimes, but our research team making sure you are given the right size to try and minimize discomfort, instructions and videos on how to insert and use the product to try and support use. I don't know if this is official advice, but I would say pop it through the dishwasher before you use it for the first time, just to soften it up.
Okay, that's interesting.
But what we're doing at the moment is we're actually trying to collate a lot of the qualitative, so experience data that exists, and also capture it from our participants so that we can understand what people actually would like out of a product that collects their menstrual fluid. But also we know can work for research, because there's sort of like a couple of sides to that. So even if you do it and you hate it and you tell us how you hate it, that's super helpful for us too.
Important.
So that we can change the way we do our research to better meet the needs of the participants of the research.
Well, that's how things get improved, right? Like, it's fantastic. Well, I really enjoyed speaking to you and being so fascinated.
It's been great to come back.
We need to talk more about periods.
You have to update us on how it goes.
Absolutely.
Yeah, I think that's really exciting. And then just being opportunistic, fantastic work that you and your team are doing. Is there anything else big happening in your life that's coming up, or?
Well, we've got our big congress next week for the Perinatal Society of Australia and New Zealand. So I'm very excited about that. I'm keeping everything crossed that it stays dry. And my heart is out there for all of my Queensland colleagues and the families that we work with in Queensland, that they stay safe and dry. So that's probably the next.
For those watching, so it's the annual congress that moves around Australia and New Zealand. So last year was in New Zealand. I think the year before was Melbourne, but this year, next week, is going to be in Brisbane, which is days away from being hit by a cyclone. So that's why our prayers are with everybody in Brisbane, and we're hoping that the convention centre does not get flooded, and that we'll all be there for the Congress.
And I know that we've got a lot of people with lived experience coming to the Congress, and also thank you so much to you both for your support of the Society in that regard. And our pre-meetings, so our clinical trials meetings, so that's Impact, where we come up with new ideas and new clinical trials to improve a whole host of things across the perinatal space. And Mel, you've obviously been very involved in the Impact Network for a very long time.
Looking forward to it.
And all the other groups, so preterm birth prevention. There's some meetings around perinatal ethics, so how we support some of those really complicated things that can happen when babies need palliative care, and decisions in that space. And stillbirth. We've got an Improve workshop, so that's best practice to support clinicians around time of loss to when families experience a loss, and bereavement care focus. So lots of fabulous activity happening next week. So that's my big jobs to focus on for the next week.
Well, I think it's been absolutely fantastic in terms of watching, I guess, the focus. So for those who are watching and listening, Nat is the chair of the Lived Experience Advisory Network, or the LEAN. We love our acronyms. That presents LEAN. So, and I guess in the last even 12 months, it's just been such a big push and focus to have more of a presence and to really come together and work in partnership. And I think watching that happen, there's so much potential in how we can get all the parents across all the different groups that are happening out there and have their lived experience be kind of, I guess, under one umbrella, but that we're working together on information and education and resources and a bigger presence. And it's a really exciting time. So it's going to be fantastic for both Nat and I to be there with the whole Lean team and just be part of the Congress. Like it's brilliant. We love it every year.
It's a very friendly society. So very friendly and very collaborative. It'd be fascinating to know how many projects and things have happened purely out of Pazance meetings where people have been together chatting and talking about ideas.
Well, I mean, you've just mentioned Impact, which is about the clinical trials. Like basically all the trials that I'm a parent rep on are pretty much Pazance Impact trials. So whether it's Platypus and WAM and all of the ones that are part of that. So to be able to open that door and have more parents present. And one of the really exciting things is that the Lean is having a symposium on the first day of the conference on the Monday. I was going to say next Monday. And, there's the opportunity, and I'll put it in the show notes and that as well, where people with lived experience, if they'd like to come along, they can apply for a free guest pass to be part of that symposium. So thank you for making that available and putting such a focus and importance on and the value of having parents at the Congress. I think it's such a brilliant step forward. It just keeps growing. It's wonderful.
So just as like a little side note to that, all of this endometrial project came from conversations with people in my personal life who were asking questions or talking about their periods and then had experienced complications of pregnancy. And it was through the lived experience of their menstrual cycle chats, as women do, and then their pregnancy outcomes that got me thinking about this quite a few years ago. So the benefits of having people just in the space together, those that have experienced it and their questions, and those that have the capacity and ability to know how to answer questions or how to put it together, it cannot be understated. I'm so excited to have more and more people with lived experience just amongst the Congress and amongst everybody there talking about things, because the first time I pitched talking about periods and stillbirth, I got funny looks like, but there was enough people over time making small comments about little bits and pieces that certainly said to me, there's something here that hasn't been connected yet, and we need to put some effort into this.
Oh, that's amazing, Miranda. Let's keep talking about periods and how it relates to a healthy pregnancy. I think it's amazing.
All right. Well, thank you so much for today. I think we've got a little bit over. So, it's fantastic. I think the conversations have been amazing. And we'll share information about the EOS study and also Pazance as well. And thank you so much. And we'd love to have you back again to get an update on how things are going.
I would absolutely love to come back. So
that'd be awesome.
Whenever you don't want to run over, though, like happy to run over, because I'll just keep talking.
Oh, it's wonderful, and it's so needed.
And we look forward to seeing you in person next week.
Oh, yeah, that's right. Yes.
It's great.
All right. Thank you. Bye.
All right. Bye.
That's a wrap on another episode of the NICU Lived Network. Thanks for joining us today. To stay connected, please make sure you're following us on social media.
And if you found value in this episode, please share, like, or comment.
We'll see you on the next episode.